Testing, testing, 1, 2, 3. Greetings, nursing students. Let's talk about anti-seizure drugs. This is a very diverse and very complicated group of drugs. They have a very wide range of activities. They have a pretty wide range of side effects too. Managing these drugs is not easy, but for the patient with epilepsy, they're essential. Please watch this YouTube video. This is a video by the Epilepsy Society in collaboration with the National Health Institute, National Health Service in the United Kingdom. So it's British. Everyone has a British accent. The neurologist has a very nice British accent. You'll quite like it, but it's actors reenacting different seizures, talks about the different types of seizures. It's very easy to understand. It'll take you 30, 35 minutes. So please view this video, then come back and view the rest of this video. I will now pause to let you do that. All right, you watch that video? Good job. Let's move on. Here are some of the anti-seizure agents we will talk about. First, we have the hydantoins. The top drug there, ethitoin, has been discontinued in the United States. Fosphenytoin is the preferred drug of this group because it's the best tolerated. Hydantoins are very powerful anti-seizure meds. Then we have the barbiturates and barbiturate-like drugs. Again, the top drug there, methylbarbital, has been discontinued. Then we have benzodiazepines, clonazepam, and diazepam. The succinimides, ethosuximide, and methosuximide. A group of others, levetiracetam. That one goes by the trade name Keppra. That one gets used quite a bit. Then valproic acid, zonisamide, carbamazepine. This drug has a lot of chemical similarities to the tricyclic antidepressants, clorazepate, and gabapentin, which is a weak anti-seizure drug, but is used quite a bit as an adjuvant treatment. Let's talk a bit about the mechanism of these drugs. Mechanisms are quite varied. Several of these drugs lock sodium channels. Without voltage-gated sodium channels, neurons cannot be stimulated. Seizures result, from systemic overstimulation of neurons that spread to other groups of neurons. Blocking voltage-gated sodium channels prevents that activity from getting out of hand. So many of these drugs block voltage-gated sodium channels. Some block sodium channels and they enhance the slow inactivation of sodium channels. These two drugs here, lacosamide, rufinamide. Some then potentiate the activity of the GABA receptor. These are chloride channels that cause hyperpolarization of the neurons. That decreases neuronal activity. So your benzodiazepines, your phenobarbitals, your barbiturates, and then clobazam all potentiate GABA receptors. Others block glutamate receptors. Glutamate is a stimulatory neurotransmitter. So felbamate, perampanel, topiramate, those block two types of glutamate receptors. Felbamate blocks the NMDA glutamate receptors. Perampanel and topiramate block the AMPA glutamate receptors. Others block T calcium channel receptors, T calcium channels, preventing neuronal stimulation. Others block various types of calcium channels. Others block the so-called H current modulators. Well, the H current channels. So these modulate the H current. And then others are unique site blockers. Gabapentin blocks calcium channels in the synaptic bulb. Levetiracetam prevents synaptic vesicles from fusing with the membrane. Perampanel has some other very unique activities. Carbonic anhydrase inhibitors will prevent neurons from self-regulating from the inside, thus toning them down. And then others will open potassium channels. Again, hyperpolarizing cells. Retigabine, for example. This little diagram shows you some of the molecular targets of some of these. So perampanel, as you can see, is a AMPA receptor, that blocker that blocks glutamate. Others block T-type calcium channels. Levetiracetam will inhibit the synaptic vessel glycoprotein 2A. A host of these block the voltage-gated sodium channel. And then others enhance the potassium channel, and so on and so forth. Let's start with the hydantoins. These block the voltage-gated sodium channels. They're very powerful anti-seizure medications. Unfortunately, they have a lot of side effects. So these are kind of the big guns you pull out when other things don't work. So these are used for tonic-clonic seizures. They're used to control status epilepticus. They also prevent seizures during neurosurgery. They are less likely at therapeutic doses to cause sedation and drowsiness, but they do have severe side effects. Children are more sensitive to the sedating effects of these drugs. They need to be monitored more closely. Unfortunately, these drugs can affect learning and memory in children. So they typically aren't used in children unless you have no other choice. So it's important to interact positively with the patient's parents and to educate them and give them as much comfort as possible. With adults, these individuals should wear a medic alert bracelet. Make sure you educate the patient on the side effects, which are many. Educate them about their lifestyle changes. They can't drive unless their seizures are exquisitely well controlled and they haven't had a seizure for, I think it's 6 months. Women need to be on birth control. These drugs are very teratogenic. Never abruptly terminate taking this medication. The abrupt cessation can induce seizures. Older patients are more likely to experience side effects. They may need a reduced dose. These drugs have a slow onset, but long duration of action. If they're used IV, they have a fast onset, rapid peak, and then if you keep giving the drug, they can have a 12 to 24-hour duration. Allergies to these drugs have been reported, so monitor for the presence of drug allergies. Pregnancy and lactation is a contraindication for these drugs. Patients with debilities may respond adversely to central nervous system depression. Don't give these to patients with impaired liver or kidney function. Coma, depression, either unipolar or bipolar. Psychoses, all of these are exacerbated by generalized CNS depression. Keep that in mind if you use these in a patient with those comorbidities. Adverse effects include drowsiness, confusion, lethargy, and fatigue. Cardiovascular adverse effects include changes in blood pressure, usually drops in blood pressure, and arrhythmias. The arrhythmias can vary from patient to patient. Gastrointestinal adverse effects include dry mouth, which can be mitigated by increased fluid intake, anorexia, which can result in pretty robust weight loss, and constipation. That can be mitigated with increased intake of fiber and the use of other medications, over-the-counter medications, Miralax, Colace, things like that. It's very important for patients on these drugs to drink copious amounts of fluid. Urinary retention is common in these drugs, although the degree of urinary retention varies from patient to patient, and then loss of libido has been reported. Probably the most concerning of these adverse effects are bone marrow suppression, severe liver toxicity, overgrowth of the gums, and then serious dermatological reactions, increased hair growth, hirsutism, and then Stevens-Johnson syndrome as well. You're going to need to watch for those. Drug-drug interactions include alcohol. Alcohol increases CNS depression with all anti-seizure drugs and must be avoided. Evening primrose, which is taken sometimes by people to calm them down, will increase the risk of seizures. Ginkgo will increase the risk of seizures and adverse effects if taken with phenytoin. Next group of drugs are the barbiturates and barbiturate-like drugs. These drugs increase GABAergic activity. They hyperpolarize cells. They decrease CNS activity. They will inhibit activity in the ascending reticular activation system, the RAS. So they depress the cerebral cortex. They alter its functionality. They also depress motor input. So these drugs may cause people to act like they're drunk. Slurred speech, altered gait, poor reflexes, those are all going to be side effects of these drugs. These drugs are used for clonic, tonic, and psychomotor seizures. They also prevent seizures before and after neurosurgery. They also prevent or control status epilepticus. Your nursing considerations for children, adults, elderly adults are the same as those with hydantoins. You have an additional concern in that barbiturates can cause euphoria. They're addictive. Use these drugs with great caution. So barbiturates come in an IV, an oral, a intramuscular and subcutaneous preparation. They're metabolized by the liver, excreted by the kidney. IV has a 5-minute onset, 4 to 6 hour duration. IM and SC have a longer onset, 10 to 30 minutes. Same duration though. Oral has a 30 to 60 minute onset, but a long duration of 10 to 16 hours. So because of their metabolism and excretion, liver dysfunction or kidney dysfunction will increase the half-life and potentially cause the drug to accumulate in the body and increase side effects. Contraindications for these drugs are the same as those for the hydantoins. Pregnancy, lactation, so on and so forth. These drugs cause CNS depression, so they cause confusion, particularly in elderly people. Drowsiness, lethargy, sedation, fatigue, hypnosis, anesthesia, and then they can also induce deep coma. They can drop blood pressure and cause reflex tachycardia. They can constipate you, sometimes pretty severely. Again, increased fluid intake and fiber can help with that. They can also cause urinary retention, loss of libido. They're also addictive. Withdrawal symptoms are common if they've been used long-term. See the video on the sedative hypnotics for the signs of withdrawal symptoms. Here's a picture of the type of dermatological reaction you can get. Those dermatological reactions are severe. They're signs of cellular toxicity. The drug needs to be held if these develop. Alcohol increases CNS depression and should not be taken with barbiturates. Ginkgo increases the risk of side effects. Should not be taken with these drugs. Now let's look at benzodiazepines. These also potentiate GABAergic neurotransmission. They hyperpolarize cells, primarily in the limbic system and the reticular activating system. They cause muscle relaxation. They're anxiolytic as well, but they don't affect the functions of the cerebral cortex. That's an added bonus of these drugs. People are much more functional on these drugs than with the other two types of drugs. These tend to be an adjunct treatment for severe epilepsy. They can, however, manage epilepsy as a monotherapy in those who need occasional treatment to control bouts of increased seizure activity. They can be used as a monotherapy or as an adjuvant treatment in those cases. The considerations are the same as those for the previous two groups of drugs. So these drugs come as a rectal suppository. We have very rapid onset, 3-hour duration, 30-minute peak. They're available also IV, IM, and oral. The oral prep has a 30 to 60-minute onset, again, 3-hour duration, 1 to 2-hour peak. IM, same peak, same duration, but a shorter onset. Same thing with IV, but a shorter peak. And those all go for 3 hours. 3-hour duration is the rule with these drugs. So these drugs have to be dosed multiple times during the day, which is an inconvenience. Contraindications, same as for those with hydantoins. These drugs cause CNS depression, then cause confusion, lethargy and fatigue. They relax muscles so they can drop blood pressure. You can get compensatory tachycardia. As a result, they can cause constipation, dry mouth, anorexia. They cause urinary retention, loss of libido. They also can cause physical dependence and withdrawal symptoms. See the video on sedative hypnotics for the symptoms of withdrawal with benzodiazepines. Don't take them with alcohol and barbiturates. Also, opioids can amplify the CNS depressive effects of benzodiazepines. Now we come to succinamides. These decrease calcium influx in the synaptic bulb of neurons. They reduce the release of stimulatory neurotransmitters. So they inhibit neuronal activity, suppress the EEG pattern associated with seizures, calm down neural activity. And these drugs are specialty drugs for absence seizures. That's what they tend to be used for, absence seizures. So with these drugs, perform a baseline examination, particularly also look at periodic hematologic studies, also liver and kidney function. Make sure you get that baseline so you have something to compare them to. I should say topiramate is also used for absence seizures. It is not a succinimide though. Monitor side effects, look for drowsiness, look for ataxia, look for dizziness, look for other neurologic adverse effects, make note of them. If they get worse, you may have to tell the doctor. Observe the period of dosage adjustment. Therapeutic serum levels should be 40 to 80 micrograms per mil. So you might have to measure drug serum levels. Observe psychiatric disturbances. This will be important to determine if the drug is working. Discontinue the drug only under physician supervision. If you withdraw the drug abruptly, you may precipitate some seizures and also clusters of seizures. Don't drive or engage in potentially hazardous activities until the response to the drug is known. Monitor weight on a weekly basis. This is important, particularly in kids. These drugs can induce anorexia. You may have weight loss, and that may affect growth rates. Don't breastfeed while taking this drug without consulting a physician. Also, don't take it while pregnant. This drug is oral. Well, these drugs are oral. 3 to 7 hour peak, so you usually have to take them TID. 30-hour half-life in kids, 60-hour half-life in adults. Metabolized in liver, excreted in the urine and bile. Contraindications are same as those for the previous drugs. No alcohol, no opioids, what have you. Adverse effects, drowsiness, fatigue, ataxia, insomnia, headache, blurred vision, decreased GI activity, nausea, vomiting, anorexia, weight loss, GI pain. You also may get direct chemical irritation of the skin. You may also see bone marrow suppression, and even fatal pancytopenia has been reported. That's not common, but it happens. You may get urticaria, rashes, alopecia, and hair loss has been reported. However, ethosuximide has relatively few side effects compared with other anti-seizure agents. Keep that in mind. So these can be seen even on ethosuximide. You'll still have to monitor bone marrow. You'll need to do CBCs with differential. Look at liver function tests, get a weight, look at kidney function as well. That'll be important. But ethosuximide is the best tolerated of this group. Drug-drug interactions include alcohol, other anti-seizure meds, and particularly the barbiturate primidone, opioids, and then other central nervous system depressants, carbamazepine, which goes by the trade name Tegretol, that decreases ethosuximide levels. The anti-tuberculosis drug isoniazid increases ethosuximide levels. You may get toxicity. And the levels of phenobarbital and ethosuximide may be altered with increased seizure frequency. If you combine those drugs together, ginkgo may decrease the anticonvulsant effectiveness of these drugs. Drugs for partial seizures, you'll see what these are in the video. These can be simple. We have a single muscle reaction or complex. We have fits or more complex sorts of reactions. Watch the video, you'll see what these mean. Carbamazepine is used for partial seizures. So is its relative drug, oxcarbazepine. And then clorazepate, felbamate, those potentiate GABA and its activity. Felbamate also inhibits the glutamate receptors, NMDA receptors. Gabapentin, which is used as an adjunctive treatment, is also used for partial seizures. Carbamazepine, oxcarbazepine, felbamate are used as monotherapies. Carbamazepine is used as an adjunctive therapy. Levetiracetam is a jack of all seizure trades. It's used to treat partial seizures, also used to treat tonic-clonic seizures and myoclonic seizures as well. Very, very versatile anti-seizure drug. Carbamazepine has a long half-life. Clorazepate has a 1 to 2 hour peak with a very long half-life. Gabapentin is not metabolized by the liver, but it is excreted by the kidney. So drugs that alter kidney function will interact with gabapentin, other drugs won't. Gabapentin is very clean in that regard. Levetiracetam has a 6 to 8 hour half-life. That half-life is increased in people with renal disease. And it interacts with these two drugs, metoclopramide, which is used for GI issues, and deferiprone as well. Contraindications include drug allergies, bone marrow suppression, which will be exacerbated by these drugs, severe liver dysfunction that interferes with drug metabolism, except for gabapentin. Pregnancy, all these drugs are dangerous to the fetus. And then kidney stones. Patients with kidney stones, these drugs will make the kidney stones worse. Adverse effects. You've seen these before, except respiratory, you get upper respiratory infections. Pregabalin, which is a relative of gabapentin, is a category 5 controlled substance. And it causes euphoria and it can be addictive. Levetiracetam has a whole host of side effects. One of the big side effects of that drug is dizziness. It can make people really dizzy. Older patients and even younger patients will be at risk for falls. You need to tell caregivers that falls are a genuine issue with that drug. Patients may need to use a cane, or you may need to keep a hold of them, or keep an arm, walk with them with the arm. Older patients may need a walker. So other CNS depressants, alcohol, anti-seizure meds, opioids, tranquilizers of any types, antacids, delay the absorption of gabapentin, medications that increase or decrease renal filtration rates will cause changes in gabapentin concentrations. So that includes ACE inhibitors, ARBs, like losartan, diuretics, like ethacrynic acid and others, caffeine, because that's a diuretic, phenytoin, the anti-malaria drug, mefloquine, mag sulfate, cimetidine, naproxen, frankly, all NSAIDs, since they alter kidney function, sevelamer, and then morphine. It's contraindicated in people with myasthenia gravis or myoclonus. So assess patients for contraindications that'll prevent severe side effects. Assess for their seizures. Make sure their seizures are improving. If not, tell the neurologist they'll find a different drug. Perform a thorough physical examination, get a baseline, compare that baseline with their examination while on the drug. Monitor lab tests, renal, liver function, and if needed, monitor drug levels if required to by the provider. So consider, that should read GI, CNS, and genitourinary side effects. Give medication where necessary in order to mitigate those side effects. Ascertain disturbed thought processes related to CNS effects. Also skin. Monitor skin to determine if the patient's having any dermatological effects. Apply bandages, compresses, and what have you if needed. Monitor the risk for infection related to bone marrow suppression. So monitor the CBC, liver function tests, creatinine clearance, clotting times, and then body temperature. Make sure they're not running a fever. Ascertain risk for things like falls, drug levels. In patients with psychiatric issues, also monitor for suicidal ideation. Monitor patient response to therapies. Make sure they're having fewer seizures. Monitor the adverse effects. Make sure your trade-off between therapeutic effects and adverse effects is a good trade-off. If not, tell the doctor. Evaluate the patient. Educate the patient. Make sure they know the drug, its adverse side effects, what they need to do, how they need to live their life, alterations in lifestyle. Monitor patient compliance to drug therapy, and evaluate. Are they better? Are they getting that trade-off? And now let's take a quiz to see if you were listening. So question 1, which is a rare seizure that only appears sporadically? Febrile seizures, myoclonic seizures, Jacksonian seizures, or absence seizures? The answer is myoclonic seizures. So these are characterized by short, sporadic periods of muscle contractions. They may last for several minutes, they're quite rare. Question 2, which anti-seizure drugs are used to treat absence seizures? Hydantoins, benzodiazepines, barbiturates, or succinamides? The answer is D, succinamides. These are the specialists for absence seizures. Question 3, a patient is on phenytoin. They begin to show bruises, signs of active infection. The nurse, that's you, should anticipate that these manifestations are due to A, drug underdosage, B, hypersensitivity reactions, C, cellular toxicity, D, none of the above. The answer is C, cellular toxicity, characterized by severe liver toxicity, bone marrow suppression, gum overgrowth, gingival hyperplasia, and serious dermatologic reaction. That's what you're seeing here. Cellular toxicity. You need to watch for that on hydantoins. Question 4. Benzodiazepines exert their primary effect on which neurotransmitter? A, GABA, B, serotonin, C, norepinephrine, D, A and B. The answer is A, serotonin. These bind to the GABA A receptor. They potentiate its effects. They cause it to be open more often. They must work in combination with GABA, but they hyperpolarize cells, decrease neuroactivation in the central nervous system. That's why they also relax muscles. And question 5. Leviter, acetam, carbamazepine, felbamate, phenytoin, which of these is used for partial seizures and tonic-clonic seizures? The answer is Leviter acetam. That's your all-purpose anti-seizure drug. Very good. Learn those anti-seizure drugs, and you will be a better nurse for it. Thank you very much for listening.